Hello, everybody. I wish all of you see us. We are for the last 1 hour just try to prepare technical things in our conference. I would like to welcome you all in our first virtual meeting in GIS with our support and collaboration with Abbott Education Network with their support with us. Today we'll have a very good session. We'll try to talk about management of cardiovascular disease in COVID-19 pandemic. Without any further ado, we'll have a lot of speakers and panelists with us, aiming today to cover a lot of topics related to the cardiovascular disease, and hopefully by the end you will learn and gain more experience with it. Today we'll try our maximum to cover how to treat patients with ACS and suspected COVID-19, how to prepare your Cath Lab, how to organize a team in the Cath Lab, how to protect your Cath Lab team and apply infection control aspect. Also, we'll touch base on the circulatory support, like ECMO in the Cath Lab. Is it important to have it during the COVID-19 epidemic or not? Also, how to deal with the technical part, like inventory, to keep it in the Cath Lab, or you leave it outside, how to handle it between staff and the other staff. Also, we'll share experience from different countries, and we'll take it from there. We'll have our three speakers from China, Italy, and Spain, and we'll select the top three countries because they already have a great experience of how to handle COVID-19 epidemic. So our first speaker will be Dr. Jin Wan. She's the Chief Physician Supervisor and Deputy Director in Wuhan City in China. Dr. Tarantini is the President of Italian Society of Interventional Cardiology, and Dr. Javier Escaned is a Professor and Head of Interventional Cardiology Section in Milan, Spain. And we have our panelist, Dr. Sun Fishing. He's a Professor and Director of the Cardiac Cath Lab in Beijing in China. Dr. Abdullah Shihab, Professor of Internal Medicine and Cardiology, Vice President of GIS from Emirates, Dr. Musa Akbar from Kuwait, Interventional Cardiologist, and one of our great member in GIS, and Dr. Khalid Thani, Interventional Cardiologist from Bahrain, also great member in GIS. So without any further ado, we'll start with our first speaker, Dr. Wan, will talk to us about the China experience of handling COVID-19 epidemic and patient, and also she will nicely and thankfully will share with us her experience how to come back to work after this epidemic done in her city. Dr. Wan, please, the stage is yours.
Hi, this is Jin Wan. Actually, I'll share my screen with you together. So could you just exit from your screen, then I can use my sliders right now. Yes, okay. So actually, I just have been working at the frontline fighting against the COVID-19 for almost 3 months, and been given some invitation to attend anti-pandemic worldwide webinars. I have summarized some essential questions regarding COVID-19 related cardiology issue. I hope this kind of information will be helpful. So the first question is, for the standing patient with COVID-19, what shall we do? Actually, AMI is one of the most life-threatening cardiovascular emergency. So for those kind of patients, thrombolysis is recommended, and the third-generation thrombolytic agents are preferred. But optimized medical treatment should be taken as much as possible, like primary PCI and rescue PCI. So of course, we must balance the risk of virus spreading and cardiovascular emergency. So in response to the epidemic, a modified workflow from imagining AMI patients was developed in our center. This is our experience. So for those patients, first of all, we should give a correct diagnosis, not only for STEMI, but also for COVID-19. We just ask the patient's history, do EKG for them as soon as possible, and test body temperature and do the chest CT scan. I believe CT scan is a very good method to judgment because we could get the results inside 1 hour. And also nasopharyngeal swab, blood collection for specific IgG antibody. So if the patient suspected or confirmed COVID-19, we should admission them to isolation wards and do the consultation. So if the patient is, didn't have seriously pneumonia, so we have STEMI less than 12 hours without contraindications to fibrinolysis, we will treat them with thrombolysis strategy. If success, we will elect a PCI after they recover from pneumonia. If failed, we will send them to Cath room and do the rescue PCI. Although primary PCI or emergency PCI is an effective reperfusion strategy, especially for STEMI cases, its role had to be relatively weakened in the context of COVID-19 sudden outbreak, because we lack of negative pressure catheterization zone. This is the big problem. So if the patient's STEMI time lasts more than 12 hours, we will evaluate their risk assessment. If it's ongoing symptoms and people keep the chest pain and has other symptoms, or the hemodynamic instability, so like the blood pressure is lower and suffer the cardiac shock, or they have malignant arrhythmias. If the answer is yes, we'll transfer to Cath room with protective isolation and do the emergency PCI. So after that, we'll continue therapy them in isolation wards. If the patient has the serial pneumonia, and after the consultation, and because if some patient has ARDS, has high fever, then we will just do the conservative therapy in isolation room wards, and elective PCI could do after the recovery from the pneumonia. So if the patient temporarily exclusion of COVID-19 throughout, then if the STEMI time less than 12 hours, we will use the thrombolytic strategy like this protocol. And if the time more than 12 hours, then we still do the risk assessment and choose another procedure and going through until the patient could be, safe. We still have an other workflow for outdoor patients and some emergency patients, like heart function failure. For the ordinary patients, we just investigated COVID-19 at outdoor patient room or in the emergency department. And we do the CT scan, test the antibody from blood serum, and also do the RT-PCR for the swabs or sputum, and then transfer them to the buffer wave and do another RT-PCR AC after 24 hours. If it's positive, we will transfer them to designated hospital. If negative, just transfer to general wards in our hospital. So if the patient RT-PCR AC is positive, directly transfer to COVID-19 designated hospitals. If CT or antibody negative, we will admit it to the isolated ward, and if the suspected or confirmed COVID-19, transfer to designated hospitals. Excluded, transfer to general wards. So for critical patients, we have the emergency care, and we still have to investigate COVID-19. For those suspected or confirmed patients, just to transfer to a designated hospital. Excluded, and then to the buffer wards. After 24 hours, we will just test the RT-PCR again, and then if the negative, transfer to the general ward. That's our protocol. Actually, if we decided to do the primary PCI or SQ PCI, we have to prepare the interventional emergency systems like specific prisoner. We need those health workers, and we need to prepare the cast room. And we still have to prepare some material and equipment, and also the emergency procedures, as I just showed before. Actually, this is the cast room designed for the COVID-19 and infected disease. We need negative pressure ventilator cast room, but unfortunately, we didn't have this kind of cast room, so we just have normal cast room. So we rebuilt it. We just use it to do the primer PCR. This is our cast room, and for the material and equipment, we need gloves, goggles, shaders, cap, boots, and 95 masks. And we still need plastic cover, super air purification, and the sterilization system, and ultraviolet light disinfectant. So, this is the personal protective equipment category. And we divided the PPE into 3 categories. This table shows the detailed content of each level of protection. Actually, different levels of protection will be used in different clinical situations. This is the PPE category, class 2 plus. Actually, this is we just address it like this when I contact with the patient. We just take 2 face masks, 2 medical caps, 2 pairs of gloves, and 2 pairs of boots with those protective shoes. And if we prepare to do the injection, provision, and HDS, like we do the primary PCI, we should just like this. Add another 1 cap, another 1 surgical gown, 1 pair of gloves, and 1 pair of boots. And this we just work just like this when I do the primary PCI. And if we need to do the nasopharyngeal gel, swab, gastroenteral catheter, or intubation or tracheotomy, then we just like this. So I think something details of donning and doffing expected from Italy will give us some detailed presentation next. And now I will show you with the case report. A 74 years old male, chief complaint chest pain for 1 hour, and he has essential hypertension. And now this time diagnosis with novel COVID-19 virus pneumonia. And this is what we just came in the hospital, and we find it's syneurysm, and we can find the ventricular premature bits here, and we see ST segment and TP almost normal, just the PR interval was a little bit prolonged. And then after 2 days, we find at 9 p.m., we find the EKG change because the patient said he was chest pain. And we find other like the V1 to V6 ST segment depression, and also AVR as ST segment elevated, and also has 1st degree intraventricular block. So maybe the patient has the very specially type of STEMI, like the maybe left main occlusion. So we are so worried about it. But after half an hour, the patient's symptom relieved, and he didn't feel any chest pain again. And we did another EKG. It's like magic, almost normal, except V4 to V6 ST segment, the T wave is very, very lower. And we find the signal bradycardia there. So the STT change is not so obviously. It's like magic. Maybe we just think out, maybe the patient has the, left main present for a while and then release because the infected disease. So we just, we didn't use any thrombolytic therapy at that time and didn't do the primer PCI because of COVID-19. And I think there is no necessary to do this at this situation. So we just keep looking for this patient. After that, we just test CK and lactate dehydrogenases, and also CKMB and hypertensive chopping. It all increased very obviously, which means this patient may be suffering SIMI, or at least has a very huge areal necrosis at the time. The dimer is super duper high. So after 10 days, we just do the EKG. You will find, V1 to V6, and also 1, 2, 3, and VVF segment depression. So we decided to do the PCI. So this is the data. Actually, the patient is left main anterior trigeminal lesions very seriously. And, this 99% stenosis at a part at the terminal of the left main. And so we just use 2 lines going through. And one is in the LCX, another, as we know, this line is not in the terminal of the LAD, is in the one of the diagonal branch. So there is the right angle here. So it's very tough time. We just take several minutes, at least 10 minutes to going through this way. And actually this patient's LAD is occlusion almost 100. Let's take a look. So very dangerous situation. This is digital batch, and this is LAD, like this. This is LCX. So after that, we do a mini crush here, and we also do the mini crush from the left main. This is the end imaging. I think now patient maybe be safety. Okay. So another question is, it having a therapeutic function. So many experts want to know if those kind of a heparin could be used for those patients. So my answer is yes, especially used for critical patients. So as we know, this is the structure of the pulmonary alveoli. As we know, coronavirus 19 virus enters into human type 2 alveolar epithelial cells via the receptor ACE2, and it will lead to immune response and result in exaggerated inflammation and injury in critical patients. So why should we use the anticoagulant therapy for those patients? Because the damage of the alveoli and capillaries in the COVID-19 patients, we can see the formation of the pulmonary microthrombosis from the autopsy results. So microthrombosis formation has also been observed in the blood vessels, especially in vein. For the critical COVID-19 patients who need to be bedridden for a long time by oxygen treatment, or who are on a non-inversible or inversible mechanical ventilatory, so they have high risk of VTE. Most of critical patients, their D-dimer is super duper high. I find the patient has 100 times higher than we. So we should do that. And this is the paper just published from the General Hospital, Wuhan University, Zhibinglu's team, our team. And we found the patient whose TNT level obviously elevated, easier to have acute coagulopathy. And also the dimer level was higher than normal group. So I still another paper just to show patients meeting SIC or with markedly elevated D-dimer may have benefit from the anticoagulant therapy with heparin, because it will reduce the 28 days mortality. Actually, when is the right time to start this kind of treatment? Actually, in my opinion, for the critical patient, it should be routinely used to prevent thrombosis in the lower extremities and pulmonary microthrombosis, and also PE, pulmonary thrombolysis, pulmonary embolism. And also for patients at high risk of VTE, EVT ultrasound screening can be carried out if condition permits. The critical patients who suffer ARDS will have multiple organ failure, especially coagulation dysfunction. When the patient has DIC complicated with hypercoagulable state, we're given a therapeutic dose of unfractionated heparin or low molecular weight heparin. During the treatment, the glottulin bleeding function index should be monitored. So we prefer to use the low molecular weight heparin calcium 0.5 milliliter once a day. If the patient's age older than 17 years old, we prefer to use half dose. So we should know, the patient should know contraindications for anticoagulants. And patients with anticoagulants contraindications should be treated with lung compression. So the last question is, what proportion of patients have myocarditis, heart failure, or arrhythmia possible attributed to the viral myocarditis? This question is very interesting because we got some data from the heart autopsy show degenerated or necrosed myocardial cells are present, and along with mid-infiltration of monocytes, lymphocytes, or neutrophils in the cardiac interstitium, but no research point out that those change related with the virus myocarditis, because we cannot find any virus genome from this kind of area. I have a patient who is 29 years old, and she got a palpitation, and we do the EKG, we find the T wave inversion compared with the EKG he did before he had this kind of COVID-19. She has symptoms, her TNI is a little bit higher, and she has the change of the EKG, but we did the echocardiography, it's normal. And we also did MRI for her, and it's normal also. So maybe we need more, autopsy data to show if the patient has the, myocarditis related with the virus myocarditis. And with still many patients who has heart failure and arrhythmia, like the atrial fibrillation, but I believe it's all because of ARDS and hypoxia due to the organ dysfunction, maybe not because of the virus myocarditis. So that's all my presentation. Thank you for your attention. Thank you very much.
Thank you very much, Dr. Wan. It's a very good presentation. You cover a lot of good topics. I think what we're going to do is we'll go to the next speaker. I already received a lot of questions from the audience, but we'll keep it to the end. And I'll encourage the audience, please, if you have any question, just send it to me. I will just kindly deliver it at the end of the presentation to the audience, sorry, to the speakers, to have a good discussion. So from there, we'll go to Italy, go to Dr. Tarantini. Dr. Tarantini?
I'm here. Could you share my video? Because I don't see my video.
Hold on, I stop it. Yes.
Okay.
Yes, we do.
Yes, we do. Okay. So thank you for having me. It's a big pleasure to be part of this webinar. And after the previous presentation, my task is going to be something that still belongs to the hospital environments, but is mainly focused on the lab. But before getting in, getting deeply to the focus of my presentation, I would like to share with you my roadmap. That is, first of all, I would like to share with you the Italian COVID-19 situation, to discuss and share with you standards and control measures to prevent the introduction and spread of the COVID-19 in the lab. I think it's very important also to make the points of the difference between the hospital versus the community-acquired COVID-19, because the rules are completely different, because in the hospital we have vulnerable patients, vulnerable people. Is not exactly like that in the community. So we need to be particularly aware to avoid to permit, the COVID-19 to entry within the hospital. The last 2 points are the impact of COVID-19 outbreak on ACS and TAVR, and finally, the impact of COVID-19 shadow, not the direct cause of pneumonia or other things, but to see the implication of having a COVID-19 outbreak in your country in terms of mortality for other disease. Having said that, I think my first slide is just to share is an overview about the first ranking of the total case that belongs to US. Then we have Spain. The third place is sadly occupied by Italy. Then here in red, you have the new deaths per day. And here you can see US, Spain, and Italy. But actually, if you look at the third to last column, you see the death per million people. As you can see, US are 128, and the rising is very steep, because 2 days ago, this rate was 30 people per million people. Okay, but if you look at Spain, it's 450 more or less, and for Italy is about 400. So there is a clear disconnection between the total case and the mortality per million people. How can we put together these two pictures? We can do that by showing and sharing with you the Italian situation. As you can see now, we are seeing a reduction, a dropping of the new cases, and parallel is also the dropping of the new deaths. But if you look at the difference, at the distance between the blue and the red line, there is a time lag of 3 to 4 weeks. That means that you have a disconnection in terms of new cases compared to the rate of mortality that has this time lag of 3 weeks. So when you start having a lot of infection, you have to wait 4 weeks to see rising the rate of death, the prevalence of death. It's important to read, the previous table. So moving ahead to what is the World Health Organization related to the definition of COVID-19. What is important to understand is this is a very generalistic definition that do not distinguish between hospital or community. This is just a general definition. So how can, when you meet the criteria for a definitive diagnosis of COVID, when you have at least 2 symptoms, that means fever plus something else, cough or shortness of breath, plus an epidemiological feature, that means travel or residence in an area of local transmission, contact with confirmed or probable COVID-19, or need for hospitalization. The third point that has been recently reviewed by this last release of the WHO, 22nd of March, where the WHO recommends to test vulnerable patients and healthcare workers, making a clear distinction between community setting and hospital setting. So based on these 3 pillars, you will distinguish 3 possible situations. Suspected COVID, that means that you meet symptoms plus the epidemiological findings, but you don't have the test. Probable, when you don't have an available test. You have tested the patient, but you don't have the result. And finally, they confirm this when you have a positive test, whatever is the symptoms or the epidemiological aspect. Having said that, let's see how we modified this definition in Italy and mainly in the hospital setting. So we got rid for the need of having 2 symptoms. So you just need at least 1 symptom that might be fever or cough or shortness of breath without any clear cause, like for instance, acute heart failure or other things. We got rid of the epidemiological aspect because always you need an hospitalization. Let's see the 3rd point. So you can get rid of this because all the patients in the hospital are hospitalized for that, and there is everywhere the risk of local transmission in Italy. So at the end, the point is to make more tests on the patients, and we treated the patient as follows. All the emergent and urgent cases while waiting test result, because all these patients got a swab, a test, while waiting for the result, we consider all these patients as a COVID-19 positive patients. So we wear PPE, as we've seen in the previous slides, but I will go more deeply in detail in the lab. Related to the elective case, the first rule was to postpone, to push back the agenda and the list until, a different phase of the outbreak. Then you have to reprioritize this patient according to the real need to be urgently or semi-urgently hospitalized. And all these patients will be tested before the admission. So that means that 3 days before they got tested, and only after the result of the test, if it is negative, they will have access to the hospital to be treated invasively or other things. Having said that, let's see the first 2 points. What is important is to have protocol in place. Protocols matter a lot. I will show you why. But the point is that you need to create a kind of standardization and control measure that need to be shared to prevent the introduction and the spread of this disease. So this is our consensus. So Italian Society of Interventional Cardiologists, the name is GISE, the acronym is GISE. This is the list. It's very simple and pragmatic. And you can use tomorrow in your daily practice. That means we tackle general management. That means a checklist in the lab, checklist of the crash cart. Then what to do before the COVID-19 patient arrives to the lab, procedural donning and doffing, what to do peri-procedurally, and what to do post. So this, if you want to read this document, it has been recently published on catheterization, cardiovascular intervention, and has been endorsed also by the SCAI Society of Society of Cardiovascular and Geography Intervention of the United States of America. So it's, I don't have the time to show you the movie, the tutorial, but you can find out in this website, and it's useful because it's a kind of refresh. It's a kind of, memo that you can use when you have the patients, and it's a kind of guides of what to do, how to don and doff in case you need it to do it. But let's review the main steps. So what to do before COVID-19 patient arriving in the lab? First of all, you need to notify the area to be prepared to accept the patient. Avoid to stay in waiting areas. Get all the other patient away from the path of the COVID-19 patient. Pre-alert the anesthesiologist that has to consider elective intubation also in patients that do not have any specific need in terms of desaturation, but has a lot of cough. In this case, you have a huge risk of aerosolization, so it's better to get the patient intubated before staying in the operating room. Only the personnel involved has to stay in the room. You need to avoid to have a kind of, a kind of crowded situation in the room. You just need to have the people that needs to do something. And at the end, you have to wear surgical mask before the entry in the lab. So you have to identify one dedicated room. This is as you can see, this is the way to the lab for, to get the patient treated, for instance, for primary PCI. Everything is very clear. No, there is nothing, in the path, in the middle of the path. Second point, there is a sequence you can print out and hang on the wall, but this is just to refresh all the steps. First of all, you have to do an hand hygiene, then you have to start with a shoe cover, then you put the first disposable gown, then you have to go with the disposable respirator that is, in case of COVID, FFP2 or FFP3 in Italy. Put on hair cover, and at the end you go with a goggle or face shield. At this point you perform another hand hygiene, put the first pair of sterile gloves, put the second sterile gown, and do not tie inside. This is very important because when you make the doffing, you don't need to, to try to do something behind, and need to be very easy to get it off. So you need to avoid to tie inside the gown and put the second pair of sterile gown. This is the way we accept the patient. As you can see, all the people is, properly done as a proper, wear all the things, gowns, shields, masks, etc. And we close immediately the door to avoid any possibility of aerosolization. Let's skip to carry on. Okay, let's see if I'm able to carry on. Okay, pardon me. I will go back another one. Okay, what about the doffing? The doffing is even more delicate because first of all, you start with the hand hygiene, then you have to remove the gown like that, together along with the gloves, okay? And at that point, you drop it in the dustbin without pushing it to avoid the aerosolization, okay? Then you have to remove the shield like that, not from the forefront, but from the back or the lateral part of the face shield. Then you perform a hand hygiene and remove the air cover. Then you remove the shoe cover, remove the internal gloves, perform another hand hygiene, and step out of the operating room, closing immediately the door. At this point, you have another cart. You need to wear another gloves, and with these gloves, you have to remove the facial respirator from the back, like that, okay? This is very important. So at the end, you need to keep the door closed for 1 hour to permit, to have the aerosol that drop down on the floor. At that point, you will go with a terminal clean that takes, at least half an hour. So you have to calculate that you have some system delay if you need to perform, 2 or 3 urgent cases. You need to foresee this delay. So the point is that donning and doffing is just one point of a 10 points protocol. It is, as you can see, the point 7 is always wear properly the PPE, but we have other points like test every patient, like reducing the number of elective cases, organize the staff, train the staff, active surveillance. If you apply the full protocol and you see the results in one department, it's going to be published in, I think, a few weeks in Circ Intervention. As you can see, there is a dramatic drop in terms of infection of the healthcare providers from 13% to 1.2%. So having a protocol in place matters a lot. You need to be prepared to follow the rule. So if you digit on WikiHow, this is very curious and interesting. If you digit on WikiHow, do everything wrong in impending pandemic, as you can see, there is something that is vital, it is imperative. That means in the hospital, you need to test the patients and to have PPE for the healthcare workforce. This is extremely important, whatever is the stage of pandemic. If you're coming in, if you're going through, and if you start coming out, The only things that remain vital, besides the fact that you tackle emergent, urgent, and elective case, is the need to make tests and to wear to protect the healthcare personnel. So let's review very quickly the last 3 points: hospital versus community. This is very important.
2 minutes, Dr. Tarantini, more.
2 minutes, okay. 2 minutes more. This is the difference from Germany and Italy. As you can see, the lethality rate is 1.5% against 12%. Why it happens? Not because the virus is different, but because the mean age of infection is 47 in Germany compared to 75 in Italy. But the death by age is quite the same, it's copy and paste. That means that in one case, the outbreak was mainly the source, was mainly the community in Germany. On the contrary, was the hospital-related infection, the main source of infection in Italy. So let's keep these points. So let's see what has happened in Veneto, for instance, in my institution about ACS. There has been a significant drop of unstable angina or non-STEMI patient, even though there is, quite a stable situation for STEMI compared to 2019. And the point was the following, that what is different from the past year is the prolonging of pre-hospital delay. That means symptom onset to first medical attention of the patient is 100 minutes longer. That means that the patient doesn't want to get in the hospital, but the hospital delay was pretty the same. And this is the reason why we have seen more complicated acute myocardial infarction. Related to the antiplatelet therapy, I think it's important to know that clopidogrel has, works less in case of COVID patients that are treated with antiviral agents because of the changing of the first pass at the level of the liver. So you have more non-responders. This is the opposite for ticagrelor. So my recommendation is to use almost in all cases when these patients are fully treated because of COVID with a prasugrel, and when you have older patients, to reduce the dose to 5 milligrams per patient on 10 milligrams. This is the TAV situation. When you in the outbreak, we reduced on 90% the TAV activity. That means according to the length of the lockdown, you might have a reduction of the final number of TAV performed throughout Italy from 22% to up to 50%. So this is something that you need to consider. This is my last slide. Just to say one thing. With the COVID shadow, we have the mortality of COVID, that means pneumonia, ARDS, but there is an even more important increase in the overall mortalities. If you look at the first 3 weeks in March 2020, compared to the 5 years from 2015 to 2019, there is an increase in the overall mortality of at least 50% according to the decades of age that you consider. That means that a lot of patients with stroke, acute MI, pulmonary embolism, other pneumonia stay home because they don't want to get the hospital because they feel unsafe. So having said that, we need to think about the restarting of the procedure. This is the real challenge for the future. And having said that, I would like to hang in there all together as one to try to sort out this very deadly and sad situation throughout the world. Thank you.
Thank you very much, Dr. Tarantini. It's an excellent, amazing presentation as usual. You cover a lot of points, and I'm sure you do have more than this to say. We'll keep it to the question and discussion at the end. So now we'll go to Dr. Javier Scanid to give us his presentation. Then we'll open it for discussion. I already have a lot of questions from audience, and we'll leave the panelists to the end. Javier?
Okay, thank you very much. Sorry, I thought that you were listening to me. Thank you. I'm just going to share with you some of the views on the interventional cardiology practice from Spain, from the Spain perspective. You are now seeing my slides, and these are some of the topics that I will be addressing in the presentation. I will go very quickly over them with you. First, of course, to highlight what is the position of Spain into this global pandemic. As you can see, the number of cases of Spain is It's quite high. Now we have more cases now in some countries. You can also see that the number of cases over the time period that you see in the slide is decreasing. So we are going, looks like the surge is over. The mortality that we have, as it has been highlighted by Professor Tarantini, is also quite high compared with in terms of death by volume of inhabitants. It probably has to do with the age of the population, both in Italy and Spain. Most of the mortality is concentrated in elderly people. And that's also because we are really looking forward to see mortality adjusted to age in future studies. And as you can see here, you see the week-on-week change in COVID-19 hospital deaths in hospital. You can see that, like Italy, we are going out of the surge of cases, and actually we are seeing a negative decrease now, which is very positive. The UK are just starting into this, and the US, for example, have not started yet this stage. So what is the key message that I wanted to convey first? It has to do with the disruptive effects of the pandemic on healthcare services. And the narrative is very similar in China, in Italy, in Spain, the UK, and the USA. It really comes very, very quickly. And the key message is therefore that you have to prepare your interventional cardiology unit before the surge of COVID cases takes place. Here you have some Twitters by my friend Ajay Kirtan in New York, where he was, highlighting the huge surge of cases that they had a couple of weeks ago. Now, like other scientific societies, in the Spanish Working Group of Interventional Cardiology has also issued recommendations. I'm not going to go through them because they have been already covered very nicely by our colleagues from China and Italy. But you have here on a graphical way some of the measures that are recommended, which has to do with coordination of the team, use of masks and for the patients, and then for the personnel, of course, going through the process of donning and doffing that you've seen before. There are different variations to this, and obviously you will have recommendations from your local occupational health departments. But what I wanted to highlight is that protection is not just a matter of PPEs, of personal protection equipment. As a matter of fact, these actually are the least protective measures. It's the least protective measure that we have. It comes at the very end of a number of measures that you have to enforce in order to protect yourself. So, for example, obviously, the safest will be elimination of the hazard, which means, for example, thrombolysis in patients with STEMI and COVID-19. You will not have these patients in the Cath Lab, and therefore you will be completely safe from a perspective of infection control. But you could also consider out of STEMI that deferring or staging cases, for example, in non-STEMI, can be a good way of eliminating the hazard. Substitution. A good example is, for example, to perform bedside procedures, like could be an insertion of a Swan-Ganz catheter or an intra-aortic balloon, something that in some occasions you will do in the Cath Lab, a pericardiocentesis, for example, but in this situation with a COVID-19 patient, you may opt by doing a bedside procedure and therefore substitute the risk and avoid transportation of the patient, from a different hospital or inside the hospital with the inherent risks associated to this. Engineering controls. Well, Professor Tarantini showed us how to do this in the Cath Lab, and you can change your Cath Lab's structure. There are engineering controls that you can modify, and you can summarize this in designating a specific Cath Lab and modify it to reduce the possibilities of infection. Change the people work. This is very interesting, and it's actually something very challenging. In some countries, and Spain was one of them, interventional cardiologists typically do not wear a face mask or a cap. So the culture of working in an environment of biological hazards is very poor. And therefore, it's very difficult to implement this. It's one of the most challenging aspects. Aspects like, for example, social distancing in the Cath Lab are very important. People should not gather in the coffee room in the way that they were doing before. That you should enforce a very strict hygiene at every time, you know, with computers, with all the material that you have in the Cath Lab. And finally, the personal protection equipment that has been discussed before. So here you have, again, a short list of the engineering controls that you can introduce to make your Cath Lab, your designated COVID-19 Cath Lab safer. I'm not going to go through them, but again, to emphasize that this is something that is really important, because, you know, things that making a decision on whether you keep the PCI hardware inside the Cath Lab for COVID-19 patients, and therefore you are not going to take that material outside. Or on the contrary, if you want to keep all the balloons and stents out of the Cath Lab so they don't get contaminated, and find a way of handling them safely, you know, to the people that are working inside the COVID-19 Cath Lab, is something that you have to decide. For example, in our case, we do not take our lead aprons out of the Cath Lab. We leave designated lead aprons inside, and they are disinfected later. We always wear a gown under the apron, so the apron is never in contact with the personnel. But you know, those are decisions that you have to take. Like, for example, choosing for the designated COVID-19 Cath Lab, one that has enough room to allow doffing inside the Cath Lab. Another consequence of the COVID-19 pandemic that has reported everywhere is a drastic reduction in the number of acute coronary syndrome cases. This is something that again was highlighted here by Ajay in this Twitter. You know, suddenly there are no cases with acute coronary syndromes. And you know, and sometimes this is something that comes at a price. We saw this in Spain. This is the most recent report of data comparing 1 week before the COVID-19 pandemic with another week during the COVID-19 pandemic. And you can see that this is all over the country. So it is much more marked in those regions of the country that were heavily affected by the surge of cases, like Madrid, for example, where I work. But overall, you can see a drastic reduction in the number of primary PCI, all type of PCI, diagnostic procedures, and obviously a huge reduction in the number of structural interventions. I'm going to show you just one example of the consequences of this decrease of ACS cases. It's a 53-year-old gentleman that during the surge of cases has interscapular pain for more than 24 hours, but he's afraid of coming to a hospital or sick or calling 112, sorry, to seek to consult, because he's afraid of getting infected with the COVID-19 virus. He knows that, you know, emergency rooms are overwhelmed, etc., etc. So he stays at home, but later he has a syncopal attack. That's of course too much. So they make a telephone call and he's transferred to hospital. Now, of course, because of the pattern of pain and the syncope, there was an urgency was performed to rule out the aortic dissection. And actually the patient did not have aortic dissection, but the CT scan actually demonstrated that it was pericardial effusion that was, of course, further studied with transthoracic echo. So pericardicentesis was performed and it confirmed that it was hepatic effusion, of course, and with cardiac rupture suspected. Only 15 cc's were removed to prevent decompression. The patient was translated to the surgical theater where a lateral wall rupture contained was found, was treated with a patch, and the patient evolved favorably in the hospital. So, you know, and actually later the coronary angiogram disclosed that, you know, this was one of the situations where you have a small branch that was occluded probably during the acute event that had led to this cardiac rupture. We had communications from many colleagues in Spain, and also I know from Italy, that they are seeing too many cardiac ruptures. They are seeing over a couple of weeks more cardiac ruptures that they have seen in a whole year. And I think that this is one of the consequences, of this decrease in acute coronary syndromes that we are seeing during the pandemic. Now, how do we address, again, very broad comments just to share with you what we are doing at my institution and in general in Spain. In Spain, primary PCI remains the treatment of choice for STEMI, even in patients who have COVID-19. And we believe that that is very important because thrombolysis, probably will be exposing to a risk to these 20–30% of STEMI cases that do not have vessel occlusion. Now, we will speak more about this in a second. Now, another aspect is that when we are performing primary PCI in a STEMI patient with COVID, and we find that that is multivessel disease, we perform only revascularization of the culprit vessel. And that actually is a policy that we apply also to every patient during this COVID-19 crisis. We prefer to defer non-culprit lesions to a scheduled case, scheduled procedure. Now, thrombolysis, similar to what our Chinese colleagues were showing with us, is used in cases where we have severe pneumonia or the patient is critically ill with COVID-19, or in cases where we anticipate as a consequence of the COVID-19 surge of cases. This is no longer happening in Madrid, but it was the case a few weeks ago. We anticipated a long time transfer to hospital from the location where the patient, has been picked up by the ambulance or whatever. Well, not by the ambulance, by the hospital where the patient has arrived. If arrival to the PCI center is going to be in more than 120 minutes, and this may happen, because you have overwhelmed ambulance services, for example. Now, I was highlighting this aspect of a number of patients with STEMI that actually do not have occlusion of any major vessel. And we know, of course, that this is the consequence of the cardiac manifestations of the COVID-19 infection. It was highlighted before the existence of coagulopathies, but also we know that, in the context of the cytokine storm, you have type of intravascular coagulation, very similar to the antiphospholipid syndrome. You have also direct effect on the cardiomyocytes translated into arrhythmias that sometimes, of course, can be triggered by treatment with hydroxychloroquine. You have cardiogenic shock and heart failure, pericardial effusion and tamponade, and of course, thromboembolic complications like pulmonary embolism. So you have to keep this in mind in many situations with patients with COVID-19. Just to show you an example from our practice of a patient with COVID-19 pneumonia, this 81-year-old gentleman with history of diabetes mellitus, hypertension, dyslipidemia. He had actually a stent implanted in the lid in 2014, a drug-eluting stent. Now he's unfortunately experiencing this fast evolution to bilateral pneumonia. We have him in hospital with hydroxychloroquine, antibiotics. We have to give corticoids because oxygen saturations are difficult to keep at good levels. He develops long QT interval, and at the 7th day after admission, he has sudden deterioration, and this coincides with an anterior STEMI. An EKG suggesting an anterior STEMI. So we bring the patient to the Cath Lab, and what we find in the Cath Lab is that actually there is an occlusion of the LAD caused by stent thrombosis. This patient had a very high D-dimer levels, so everything suggesting, that you have a very high prothrombotic state, and this may have favored the occurrence of this stent thrombosis, as I say, years after it was implanted in the LAD. So the stent was successfully treated, but unfortunately, over the next hours, the patient continued to evolve very unfavorably and died as a consequence of multi-organic failure. So what we are seeing here is probably, you know, something that is an epiphenomenon of a much more complex consequence of the cytokine storm leading to coagulopathy. As I say, the patient had a very high D-dimer, and this has to be taken into consideration. Certainly, we are learning more and more how to manage these patients. Now, if in non-STEMI cases, you should be very careful in determination of troponin levels to trigger urgent coronary angiography. I mean, and again, this is just to summarize in a figure all the different situations in the COVID-19 infection that may contribute to have increased troponin levels. So the recommendation is that first, with non-STEMI patients, we always tend to have more time for testing patients. So we know if the patient is COVID-19 or not, and therefore we are in a better situation to interpret the test that we are doing and also to protect the team in the Cath Lab if the patient has to come and to do an intervention. There is a value of computed coronary angiography in selected cases. And by selected cases, I'm saying particularly when you are seeing younger individuals. You know, so it's obviously, again, a way of substituting the risk. If you are able to bring it's easier to perform a CT scan and less risky for the personnel than ordering angiogram for the patient. And actually, you will be in a much better situation if you have the whole battery of tests in these patients, analytics, and also CT scan in order to understand what is the situation before asking for an invasive procedure. And again, in cases that you have multivessel disease, sensible revascularization is very important. Again, something that you have to keep in mind, it may happen that during the search of cases, many ancillary services in your hospital that are key for the safety of complex procedures. For example, having the possibility of asking for a CT scan, having the possibility of taking the bed to a coronary care unit if you have a complication. Many of these services are not available. So the recommendation is do not embark in complex PCI whenever as possible. Focus on the treatment of gangrenous stenosis and leave other lesions for separate treatment later on, because then you will be able to apply many other resources and embark in whenever required in more complex PCI to make a good job and to perform complete revascularization. And that also applies, and I think that this is my last slide, that also applies to the cases that have a stable or say unstable angina, but not non-STEMI in the COVID-19 crisis. Of course, I mean, the recommendation is to defer or postpone elective cases, with the exception of those where you believe that the intervention is going to modify the prognosis of the patient over the next 3 months. And for that, I mean, the cases that typically we keep, performing are cases that have left main stenosis, symptomatic multivascular disease, and crescendo and stable angina, or situations where we have also evidence of extensive myocardial ischemia that can have prognostic implications. Repeating again what I mentioned before, sensible revascularization, treatment of the most relevant clinical stenosis, but not embarking in complete revascularization of multivascular disease, complex procedures that can be safely performed later, with more resources in the hospital available for the treatment of the patient, and with more time to apply intracoronary imaging, physiology, and plaque preparation techniques. So thank you very much for your attention. I look forward to your comments.
Thank you very much. I appreciate it. It's a very good presentation. From now, we'll just go to our panelists. Everyone should have one comment. Then I will I will just deliver the question from our audience. Dr. Son Fishing, still with us? Dr. Son?
Yeah.
Okay. Can you if you have any comment, please go ahead.
Yeah, but please, yeah. Okay. I think three presentations very nice. I think one command is during the coronavirus pandemic time, how to prevent the staffs in the Cath Lab. I think so many physicians are very concerned about this, and all for me it's the same. I think the two presenters has told us the detail how to prepare the Cath Lab, how to prepare the staff. So in my hospital, we at the beginning of the pandemic, we separated the staff to three groups. Nurses, two nurses, the one technician, and two physicians, the one team. So the one team is on call for 1 week. And if the one team treated one suspect patient, we should waiting the test result for the patient. If the patient is negative, we should the staff can go home after work. Otherwise, they should stay in the hospital until they test the result. Okay, and if they contact the patient with who finally confirmed is the virus positive, and all the staff that will stay in the hospital 2 weeks, not go home. So and isolated this team, and the second team that go coming and to get work. So this so the in my hospital we working like this, and the second point is how to exclude or test the patient. So every patient after even they have the STEMI or non-STEM patient first they go to the ER, and we test the ask the history and test the patient, and also if possible do the lung CT scan to exclude the virus infection. This is very important. If the patient confirmed in the ER and in Beijing, we transfer the patient to the infection disease hospital, special hospital for further treatment. This is the second point. And some experience from China, we because we have from the January to February, this the February is the peak of the pandemic, and we statistically the staff the infection data. There are 422 hospitals. There are about 3,019 is suspect infected, but finally confirmed the patient, confirmed the diagnosis about 1,000. But the most of the staff, the infected staff, is in Wuhan city. After beyond the Wuhan, there's only 1/3 of the case. But so this is why in the early time the analysis of the reason is because at the first we don't know how the virus transmitted between the people and how severity it is. But now we know that. And today, my hospital, we have the two teams from the January to February to support Wuhan. It's about 151 staff that include the nurses and physicians and manager staffs. Today they come back to Beijing, and 2 weeks the isolation in the hotel. They have the 2 times the test and also antibody test. They all the negative. So in China there are about 40,000 of the staff to support Wuhan and Hubei. And as I know, there are no no one infected. So this is the 0. So this is but in the early time that there's some infection just in Wuhan city. So I think the personal protection is very important. So in every hospital, we training every staff how to protect themselves, how to take off the personal protected equipment. It's very important because as we in the Cath Lab, we used to very simple some even I know that in some Cath Lab even no mask, no cap, but now it's totally different. So this is very important.
Excellent. Thank you very much, Dr. Abdullah Shahab.
Thank you very much, Dr. Fawaz. I think the speaker were great really to share with us their experiences and how things are now changes from China to Italy and Spain. What strikes me here, the way our colleagues in China, they're using the CT scan at the front, after the test, they do the CT scan to stratify the patients for their intervention. I think this has not been properly done in our region yet, I think, because we are not maybe yet equipped ourselves or our facilities for that. But I think we are learning from that. The things about the testing for us, I think, is is sometimes deceiving, because I can tell you I had a case just a few days ago who was like in his 50s with diabetes. He was tested like negative 2 days ago, came to us with a ST elevation in mind. So we all thought, this patient is, is negative. So I got a certify for that. But despite of that, our colleague were vigilant and they had a PPE on, and then they treated primary PCI and for that patient. But then a few days after that, because we test everyone, it became positive. So we don't know, the problem remained, the test remained for what remained like 70% sensitive. Having CT scan, I think, is important. I think we have to incorporate that in our diagnosis, and multimodality, I think, is important when we are, we're able to, as our colleague says here, we don't forget our doctors, because what happened in the world now, in Italy, I think thousands of doctors being infected. I think same in Spain, same in the States, and we are losing our physicians because we are not taking the measures. So PPE is fine, but as our colleague Javier said, is we have to change the system. We have to focus on our hospital, our staffing. So lots of things we need to do. Great presentation.
Thank you. Musa, comment before we go to questions.
Yeah, thank you very much, Mr. Chairman, and thanks for all the speakers. We enjoyed really sharing your experience with us, and it's the same in I think in the Gulf and in Kuwait particularly, that we have a tremendous decrease in number of the cases of patient presenting with the PCI or STEMI for going for PCI, also for the structure. We have noticed that there is a tremendous decrease in the amount of the patients. But just I want to share with you, for those who have experience with seeing all these cases, have you come across patients with using a triple therapy with antiplatelet, anticoagulants? Any problem using DOACs in patient with COVID patients? This is the only things I want to share with you. Otherwise, the great experience, and thank you very much.
Good. We'll deliver it, but final say from Khalid before we start our question. Khalid?
Thank you for this great presentation. Thank you, Mr. Chairman. It comes all back to the using of the PPEs and making sure that the staff is to be tested weekly. I think this is something that should be done in all the hospitals, especially with medical personnel or healthcare personnel that gets in contact with COVID-19 patients. Just a small comment for Dr. Tarantini, because he showed some of the precautions for the Cath Lab. To my knowledge, in the University of Padua, they have a special kind of Cath Lab. There is 2 doors for the Cath Lab, one for the personnel and one for the patients. I would just, ask him if what they did, like exactly, because there is, if I do remember, there is a middle corridor for the healthcare personnel to come into the cath lab, and there is another door for the patient to come in. How they managed, they closed one of the doors and then they kept, like, everything from one door, because each cath lab has a different what do you call it, architect, so this is one thing. Second thing is the financial burden for everybody to, like, provide the PPEs, especially in the cath lab. And I don't know if their experience of providing the PPEs, if there was any shortage, and how they managed it.
Okay, fair enough. Dr. Tarantini, you want to take that? We'll start. Then we'll
Thank you for your comments. So probably I was not clear because we have just one door. The point is that the operator are already wearing mask and PPE while waiting the acceptance of the COVID patients within the room. So the way was clear with the patient that came in from, for instance, intensive care unit to the lab, with the people that wear, the proper PPE, they come into the room where there are other people, doctors, nurses, and technicians that accept this patient, then they close the door. At that point, nobody used to come in and out from the room because we have a dedicated cabinet of, stands, wire, etc., that are used just for COVID case. So we have a dedicated room with one door, a dedicated cabinet, and in case of a urgent or emergent case, while waiting the result of tests that used to be available in 60 to 7 minutes, because we have the Sorin machine that will give you the result in about 60 minutes. So while you're completing the procedure wearing the full PPE, because you pretend to be a COVID positive, even though it is probably not a COVID positive in case of STEMI, okay, while you finish the procedure, you have the result of the test. At that point, you decide if you have to send the patient to a COVID dedicated intensive care or in the CCU, that is a COVID-free zone dedicated for STEMI that are, normal STEMI. So this is the flow. Related to the shortage, we didn't have the shortage of PPE because based on these things, we had almost a vanishing of acute coronary syndrome. So there were very few cases that were emergent that we considered as COVID positive were the PPI. In other case, we almost closed the elective case program. So because we need to have a test, before. I was in agreement with the colleagues before that said the test was negative 2 days before and 3 days after was positive. But you need at that point to have an active surveillance to understand if it is positive after 3 days because of a new infection that is hospital related or was a false negative of the test that you used. So it depends on the machine, because if you use the PCR test, the sensitivity is very high, is more than 80%. 80% in a symptomatic carrier. But when you have symptoms, etc., the sensitivity is very high.
Okay, great. A question for Dr. Khafir. There was someone asking about the medication, like, the concern about ACE inhibitor and statin and COVID-19. So what's your input about it? If the patient is already on ACE, do you continue? Or do you recommend that you start ACE inhibitor for a patient with COVID-19?
Yes, thank you. So as you know, one of the concerns is that because the coronavirus binds to the ACE2 receptor, and because the use of ACE inhibitors for the treatment of hypertension lead to an overexpression of ACE2 receptors, there was a concern that due to that reason, it will be, these patients will be at a higher risk of having more severe expression of the COVID-19 infection. But This, for the time being, we don't have full support that this is the case, and the recommendation at this point is that do not stop the medication. That was an initial concern. There is no solid evidence supporting, that this is the case. So statins are also maintained. I think that something that is important is perhaps more having a look into the interactions between the drugs that you are using with patients, with COVID-19 patients, and the drugs that they are taking. So, for example, just to give you an interesting hint, if you look to the type of anti-platelet agents that we use, both clopidogrel and ticagrelor have interactions with hydroxychloroquine, for example, but you have less interactions with prasugrel, for example. And this is something that we are learning more about it. I'm not at this point, but probably you should do, is just to be check that the medication that the patient is having is not interacting with any of the drugs that you are giving to the patient for COVID-19. Same with antibiotics, of course.
Good, excellent. Dr. Wan, one of our audience asked about periodic testing for the staff, like people in the Cath Lab, physician, nurses, and technician. Do you think this is a good suggestion to do periodic testing, or no need?
Testing for the serum of the antibody?
Yes.
Actually, we just test the patients on a specific IgM and IgG, because after the patient gets the virus infected, it should be IgM will increase inside 3 to 5 days after onset, and IgG, which is a titration of at least 4-fold increase during the convalescence compared with the acute phases. So, in my opinion, we should test the serum antibody, IgG and IgM, to make sure the patient, if them has the infected. Actually, there is at least 3 methods. The first of all is sweats, and sweats, we believe some secretion from the lower respiratory tract. We can get that. It's most accurate, and the accuracy should be 93%. But sputum could give another positive data, and noise swabbers maybe 63% accurate. So I think we can get this RT-PCR data also. And the most important thing is the CT scan. So we should combine the 3 of them together and then make sure the patients get the infected from COVID-19.
Okay. Just a quick question for you also, Dr. Wan, asking about the autopsy. I don't know if you have any data about it. Do you have any data about how the description of COVID-19 affecting the endothelium of coronets?
Actually, we have some data. As I mentioned before, we find some degenerated or necrosis myocardial cells are present, along with the made infiltration of the monocytes, lymphocytes, and neutrophils in the cardiac interstitium, and also sheddings of endothelial cells. Endovasculitis and thrombi are seen in some blood vessels. Those the data of the autopsy we can get right now.
Dr. Wan, Dr. Musa asked this question, and I want to ask this because we do have experience with heparin and fondaparinux in these patients. What about the NOACs, the novel oral anticoagulation in these patients, and the usage of them, and as Dr. Tarantini he showed in his lecture regarding, I think, or your lecture regarding the prasugrel and ticagrelor. Anything regarding the NOACs?
Excuse me, because your voice looks a little low. Could you pardon? I beg your pardon, please. Yeah. because
Yeah,
the voice is not.
it's regarding the usage of the novel oral anticoagulation, the newer ones like the rivaroxaban, dabigatran, and the rest of the new oral anticoagulation. Can you hear me, Fawaz?
Maybe Dr. Sun could
Dr.
help
Sun,
me.
Dr. Sun,
Because I cannot hear very clearly. Yes.
Sure. Dr. Sun will
替罗肺斑的新的抗氧，新的抗凝剂的替罗肺斑，
Oh, okay. I think maybe you just talk about Novax, right?
Novax, yeah.
Yeah, because we use the heparin for the anticoagulant treatment at first for those critical patients who lie on the bed for a long time. But after they recover and go home, if we find the DTV and we find the microthrombosis there, we use Novax, use rivaroxaban for 90 microgram per day for them. But if the patient's age is too old, maybe older than 80 years old, maybe we use 60 dose per day for them to anticoagulants after that.
Okay, great. Dr. Tarantini,
I would like to comment on this because even though you select to go not for triple antiplatelet therapy, but dual antiplatelet therapy, including antithrombotics. So now, if you decide to go, because it is COVID, as Javier told you before, and I showed in my slide, so the most, stable agents is the prasugrel. So to the best of my knowledge, I don't know that we have robust data even for dual antithrombotic therapy with prasugrel plus NOAC. So my recommendation is to go with, prasugrel. If you want to go with prasugrel, then heparin and aspirin, and then to switch, at least as long as you have a COVID positive patient, you need to go for antiviral agents or other agents that might influence the hepatic metabolism, to go with warfarin, and then you can shift later on. That's my point.
Yeah, prasugrel, we don't have it in this part of the world.
Yeah, if the patient who has the, ACS and we didn't want to do the primal PCI or other treatments, we didn't decided to do the PCI as soon as possible. And the patient has atrial fibrillation and also the dimer is super duper higher. We will use the triple anti-platelets and also anticoagulants at the same time, but not too much, not too long time. We just use them inside 7 days. And after that, we just choose one medicine for anti-platelets, another for NOAC. Use them both together for 9 months. Yeah.
So refer questions, Dr. Escanid. Someone asking about the cases. So in STEM, you already talk about it clearly. Elective cases, we talk about it. High risk non-STEMI will go to the Cath Lab. But what about the low risk non-STEMI? A guy came in, troponin maximum was only 2,000. Is pain free. Only at the presentation have a chest pain. Now walking around in CCU without any problem. Echo is normal. Do you take this case to Cath Lab, or you prefer to treat medically then do Cath later on?
I think that the basic points that about a patient that is non-STEM is that you have more time to really clarify what is the situation of this patient. Is this patient COVID positive or not? This is something that is going to help you. It's not only a matter of handling properly this patient in terms of infection control. It's also to have a better understanding of the test that you are getting, including the level of troponins. So that will be my aspect. And as I was saying before, you have even, we do not have the same access to CT scans that, for example, our Chinese colleagues had. That they had this protocol much more in place. But there is certainly a room for, when you can schedule the patients to have access to multi-slide CT scans in cases where you can really rule out that perhaps with good with clarity that this patient is not having an acute event or something that you will solve in the Cath Lab. And typically this is the situation with the younger patients. This is basically what we think. You have an elderly patient, 85 years old, with a high, pre-test probability of having coronary artery disease, it's going to be difficult to interpret a multi-line CT. So sometimes in that aspect, you have to really balance out if it is worth going into that path, or instead, considering when is the right time to bring the patient to the Cath Lab.
Excellent. Dr. Tarantini, just comment on the immunotherapy if you are on, or do you have any experience with that?
No, actually, to this point, we are running in my hospital, University Hospital, many trials related to that, but I don't have a definite answer. I'll tell you one thing. When you try to test for antibody, we have something that is puzzling, because people that has, that colleagues with the COVID-19 pneumonia are totally negative in terms of antibody. Because the point is that I don't know so far the reliability of the antibody assessment. So I cannot answer to this point unless we have the result of a randomized trial on that.
Okay. Dr. Abdullah?
I just want your thoughts of our colleague in Germany and Spain about those who are being discharged from the hospital, and there is a report that many of them died of sudden cardiac death. What was it? Was it cardiac death or something else? I mean, I've just seen a report there. Is it pulmonary embolism? Is it?
Well, I mean, it's difficult to say if it is after the patient was discharged, and I assume that is already a situation where the patient was stable and where the patient you have tested that the patient is negative. For example, I cannot comment. We don't have that much experience. What we can tell you, and of course, I mean, I'm sure that that's also your experience, is that patients who arrive at the hospital with COVID-19, they have a lot of vasoplegia as well. So these patients are sometimes there's also this big discrepancy sometimes between what you see in the blood test, what you see in the X-ray, and how the patient feels. There's a big disconnect. Sometimes the patient feels apparently much better to what the status of the blood test and different tests are showing you. And in this situation, it has happened in our experience that the patients tend to have syncope, very easily collapsed, and even sometimes, you may have in hospital death when the patient, stands up and just walks a few steps. But that's an entirely different thing. I think that Professor Tarantini, Giuseppe wants to comment something about this point.
No, it's not about this point because I'm not aware about these findings. Actually, I didn't see these reports, but we didn't have this kind of experience of sudden death after the discharge from the hospital, actually. But I would like to make a question, if it is possible, to Dr. Wan and Dr. San. So I've seen that in STEMI patients, you used to perform multi-slice CT scan in all cases. So I can imagine that you will look to the lung, but also to the coronary. If yes, I would like to know in how many cases you avoided to go to the lab because you saw clear coronary artery or you didn't see any occluded coronary artery. Do you understand my question?
You just want to know the CT scans, patients.
Did you look just for
You
pneumonia or you also the coronary? This is.
So I say that you already say multi-slice CT for patients.
Yes.
For the Cath Lab.
Actually, now when the patients went to our hospital, almost everybody should do the CT scan first. And especially for some emergency cases, we want to do the primary PCI, or we want to make sure there to do the next step, we should do that. And fortunately, the CT room is very close to our cath room. So if the patient being there, do the CT scan, we can gather the data less than 1 hour. So maybe we will delay, a little bit delay, but we have to do that because I think maybe there is kind of scaring to infected. We have to protect the physicians and the work person.
Yes,
so we have
clear.
to do that.
It's clear, but my point was another one. with CT scan, will you, did you look for just for pneumonia, or you evaluated also the coronary artery occlusion to decide whether or not you send the patient to the lab?
Yes, because this is not for make sure the patient, if the patient is COVID, it's not only for make sure the patient if they are COVID-19 or not. We just want to know after the intervention where we should be send them to isolation wards or to the normal CCU to take care after the procedure. That's the most important point. So we must make sure at first correct the diagnosis, and then we will. Because those kind of virus pneumonia, they have very typically change of their lung. So we could do this before we decided where they go.
Excellent. We have 5 minutes more to go. I would like to allow everybody to say a final word. Full of experience, especially from a China group. What things that you learn from with time, that what thing that you have been doing, then you discover that it's not the appropriate thing and you change it, so we can learn from it in the Gulf and MENA area. So we'll start with Dr. Wan.
Okay.
So final word.
Yes. Actually, I'm so excited to join this pandemic and share my experience with you guys together. I believe I always there and back of you. And if you need any help or need any information from my side, I will just supply it. And I really appreciate for this presentation. And I will believe if we can work together, we will go through this pandemic. Thank you very much. Thank you.
Javier?
Oh, thank you very much. Well, you know, it's great that we can share this experience. I mean, you know, listening to Dr. Wan and all the experience that our Chinese colleagues is so wonderful, because they were the first in facing this big problem, and they managed beautifully, actually, and like, you know, other Koreans in Asia. And we have learned also a lot, of course, from our colleagues in Italy, who were the first in Europe to have a really hard blow of the disease. So I think that, you know, it's quite urgent that we exchange this information, because there are other colleagues all around the world. Now, today we are with all the friends and colleagues in the Middle East that will have to face perhaps more patients that they have had so far with COVID-19. And it is extremely urgent that we keep exchanging information, personal experience, and of course, objective knowledge that is being obtained about this terrible disease.
Excellent. Dr. Tarantini?
I'm fully with Javier with these comments. I think the last point I would like to share is the following. So the pandemic is a moving target. It's not just a black or white picture. I think it's going to be a long and bumpy road. It's not going to be a matter of 1 month or 2 months. So depending on the stage of the pandemic or the phase that you tackle in your country, that means the beginning, the peak, the plateau, on the late phases, we need to be prepared to consider that, even though, as Javier told in his presentation, the proper PPE is just one part of the story. Whatever is the stage of pandemia, what is going to change is the type of patient that you will treat. That means when you stay in the late phase, where the rate of infection are lower compared to the ICU resources, you restart with the program of elective patients. But what is stable and will be there always in all these phases is the need to test the patients, to wear properly the PPE, and to be prepared to respect protocols until we see something that the story is finished. And also, I don't know if the story will finish because of the auto extinction of the virus, like the first SARS, that's extinguished without any vaccine, or if we need a vaccine. But in the meanwhile, what we have learned is that we need to be prepared. We need to be careful. It's not important just what to do, but mostly how to do that. Thank you.
Thank you very much. Dr. Son Fitching, 1 minute, please.
I totally agree with Professor Torretoni's opinion. I think this virus infection pandemic not only affected we practice the ECS patient, also for the selected patient. Maybe we change our way to practice, not in cardiology, in the whole hospital, how to manage the patient, and not 1 month, 2 months, maybe longer than we expected. We hope it will be finished in the soon, but maybe last longer as some of the experts expected. So we just learned a lot from the Italy, Spain, the colleagues. I think we maybe have a chance in later on have another meeting like this to exchange our opinion what happened in China after 2-3 months. Actually, there's some new thing happening in China. You may know from the news. Some hospital, the in-hospital infection happened in one hospital in China recently. So the situation kind of maybe changed. Thank you.
Khaled, quick point. You are mute, Khaled.
Yes, thank you all. Sorry for this. I would just thank everybody. It's been great. This is all the points that have been mentioned should be taken care of by all the Cath Lab personnel and all cardiovascular healthcare personnel also. It's very important to take the precaution. It's very important to make sure about your personnel that they don't acquire the COVID-19. And on top of this, you take care of your patient by the maximum that you can do and you can provide for them. And
thank you, Khaled. Thank you very much. Is Abdullah still with us? Abdullah Shahab?
Abdullah.
Okay, fine. So I'd like to conclude. I'd like to thank you all. Thank all our speaker, panelists. I'd like to thank our audience. We have more than 300 audience from 35 countries. A lot of a question. I apologize if I didn't deliver all the question to our speakers and panelists. This is the beginning of our GIS educational virtual material. We are continuing to do more as time goes. We'll do more for intervention cardiologists, nurses, and technicians. We'll advertise for it shortly. I'd like to thank you all. A very good session, a lot of good information, and definitely we'll learn from it. Thank you very much.